This week on the Back Table podcast.
This stuff can linger in the air for hours. There was a great case study looking at an outbreak on an airplane. A little girl who was pre-symptomatic but already contagious was sitting in the middle of the plane, and there were 13 people infected on the plane, 12 of whom were unvaccinated, and one who was sitting in the back of the plane, like all the way in the back of the plane, in something like row 60. And I may be misquoting, but it is a very infectious thing that can hover in the air, hover on surfaces, and really get past our typical mechanisms of hand washing and care that we can normally employ.
Hello, everybody, and welcome to the Back Table ENT podcast. My name is Gopi Shah. I'm a pediatric ENT, and today I am joined by my two brilliant colleagues, also pediatric ENTs. Let me introduce my guests. I have Dr. Romaine Johnson. He's a pediatric ENT practicing at Children's Health in Dallas. He's professor in otolaryngology and public health at University of Texas Southwestern Medical Center and at the O'Donnell School of Public Health. And he's the editor-in-chief of LIO, the Laryngoscope Investigative Otolaryngology Journal. And we also have Dr. Daniel Chelius. He is an associate professor at Baylor College of Medicine, practicing pediatric otolaryngology at Texas Children's Hospital in Houston. And at the end of this October 2025, he will be the president-elect of the American Academy of Otolaryngology Head and Neck Surgery. Welcome to the show, guys.
Thanks you so much.
Thank
Great
you
to be here.
I'm so glad you guys are here. I'm excited about our conversation today. But before we get into it, can you first tell us a little bit about yourselves and your practices?
Sure, I'll go first. So I have been I've been at UT Southwestern since 2006. So going on 20 years. And I did my medical school in Philadelphia, and then I matched in otolaryngology at Baylor College of Medicine, which is where Daniel is. I did my residency there from 99 to 2004, and then I did a fellowship in pediatric otolaryngology from 2004 to 2006, and I've been on the faculty since. Actually, Gopi Shah was our first American fellow. I was formerly the fellowship director for pediatric otolaryngology. She was our first one, and then I saw her go from assistant professor to associate professor. Of course, now she's doing her thing outside of UT Southwestern. And recently I've gotten more involved in the School of Public Health. There's a new School of Public Health here, and I've joined the faculty, so I'm a full professor there, and I'm the advisor for the MD MPH students. And I don't know, but probably by the time this podcast come out, it'll be official. I'm going to become one of the associate deans of the School of Public Health as well, managing the student affairs.
That's awesome. Congratulations.
Thanks.
That's spectacular.
Danny, can you tell us a little bit about yourself and your practice?
Well, but before I tell you about my practice, I do have to say that one of the reasons I'm sitting here is because in 2004, when I was a medical student, I rotated at the Ben Taub General Hospital on ENT, where the chief resident was this guy Romaine, and he took he and his co-chief resident took us out to lunch and talked to us all about ENT and helped get us into the field. I don't know if you remember that, Romaine, but it was you and Jim took us out to lunch, and that stands large in my memory. I mean, that was an important day. So I've been.
He still does that. He does that every quarter. I still does it with the on-service residents.
We got away from it. I feel bad. Unfortunately with COVID, we're going to talk about vaccines and things like that. We had to slow down a little bit, but we're trying to get back into it. I do think it is important to have time to break bread and get to know each other and just relax, because the operating room experience, the clinical experience can be very intense at times. And I know I can be especially dogmatic and like, okay, come on, we got to get out of here. There's 10 more patients left to be seen. You're taking too long. Move it.
Well, it was important back then. I'm always grateful for the mentorship. So many brilliant mentors when I was a student at Baylor, but you were up at the top, so thank you. I left Baylor Med School, went on to residency at Baylor, far way across the street. And after I completed my residency, I went on to fellowship up in Kansas City at Children's Mercy Hospital and stayed there briefly on the faculty for a year. And really loved getting to take care of a huge population that stretched all the way across Kansas and through much of Missouri. It was a lovely opportunity to meet a wide swath of humanity. And for family reasons, we needed to get back to Houston. And so I actually went into private practice for 3 years and was in a comprehensive general otolaryngology group doing kind of secondary to tertiary pediatric otolaryngology, but also doing a lot of general ENT care for my patients' grandparents and parents, and really got to know a whole community very deeply in those 3 years and learn a lot about being a doctor from my patients and my nurses and my community. It was a wonderful opportunity that still informs a lot of the way that I practice medicine in academia today. And so I've been at Baylor College of Medicine and Texas Children's now since 2015. They recruited me to come get to live my dream, honestly, to build a pediatric head and neck tumor program with colleagues from MD Anderson and colleagues from Baylor. And that's what I've been doing now for about a decade. I wear one hat as your local friendly tube and tonsil doctor and another as a pediatric head and neck surgeon. And it's an exciting time for us right now because we've just announced a collaboration with MD Anderson, the new Kinder Pediatric Cancer Hospital, that is going to be a new step forward for us to put together the best of the two institutions in the care of children. So I literally wake up and have my dream job every day, and it's a blessing.
That's awesome. Well, I'm super excited for our conversation today. The idea really was from the recent triological meeting in New Orleans in May. At the time, you guys put on this really in-depth, really brilliant, timely panel on ENT manifestations and measles. There was other infectious diseases discussed as well, like diphtheria, et cetera. And at the end, there was definitely a discussion on how to address vaccine hesitancy. And I thought, well, why not, have you guys come onto the podcast, because there's, this conversation is something that's relevant. It's good to kind of keep talking about it. And especially for, those who may not have been able to attend. So just to kind of give us a little background and to set the stage, what is the hype about measles? Is it because it's so, quote, contagious? Tell us a little bit of background about measles.
It's funny, this is such a weighty topic now, isn't it? And
right.
It's just amazing that, I went to medical school. It started in 1995. I graduated in 99. And, these kinds of things, these kind of conversations we didn't talk about it as much. It was more historic, or you were learning it so you could learn about like how the immune system works and how vaccines work. And now we're back to where okay, we need to start thinking about well, how does the disease present? Where are the ENT manifestations? But I think, overall, I think most people in the audience hopefully know that measles is highly contagious, respiratory viral infection. It's airborne spread. It can be in the environment 2 to 3 hours after the person who has the virus leaves. It's highly contagious. I think the R0 is 12 to 18, where COVID is 2 to 3. So very, very contagious. And fortunately, we do have a vaccine that's highly efficacious. It's the MMR vaccine. Hence, that is part of the reason why it's now in the news, is because there's a lot of vaccine hesitancy, and as well as, unfortunately, misinformation and disinformation. Most kids should get their vaccine between 12 and 15 months. You get a booster around 4 to 6 years, and it is highly effective, 97% with 2 doses. And herd immunity, which is one of the key concepts that we really need to focus in on, and it's a reason why maybe measles is making a comeback. You need about 95% of the population to be immune to it, to have herd immunity. So for even that 5% that isn't vaccinated or can't be vaccinated, or the vaccine is not as effective, they have an effect immunity because everyone else is. And of course, now we're seeing resurgence of the measles virus. It was actually declared, I was doing my looking up and doing the research, it was declared gone, eliminated from the United States in 2000.
That's why in medical school you probably didn't hear about it.
Yeah, 25 years ago. It's man, measles is gone. We were celebrating. Yay. Of course, I was starting my residency then. I was not even thinking about measles, thinking about ENT. But of course, now, there is recurrence, and Texas, of course, had a big outbreak, but it actually spread to other states. I think about a week or two ago, they said that the outbreak in Texas is over for this season. It is important to remember that measles is seasonal, so we may start seeing more seasonal effects. And of course, WHO is now, the World Health Organization has said that vaccine hesitancy is a top 10 global threat. And, I encourage the people listening at home to go to WHO's website, to go to other reliable sources and really look at the impact of vaccine hesitancy.
I did a lot of the same, I think, reading together to prepare for our talk in New Orleans and today. And it's funny, when my wife and I were talking about me coming up to the office to record this podcast, she said, what are you guys talking about? And I said, oh, the measles. And my wife's a pediatrician. She said, really? You're talking about measles? You ENTs are talking about measles? And I said, well, yeah. And she said, have you learned anything about measles since your global health lectures in medical school? And I said, well, we've done a bit of reading and things, but it is striking to me when you think about the diseases we worry about from an infectious standpoint. Boy, we worry about, Ebola with an R0 of 1.5 to 2 versus, as Dr. Johnson said, an R0 of 12 to 18. And that means average of 12 to 18 people infected by each patient with measles. But there are articles that have shown that in certain areas at times that infectious number could be 770 in one article. And so this is not like the common cold where if you washy your hands, you can potentially avoid it. This stuff can linger in the air for hours. There was a great case study looking at an outbreak on an airplane. A little girl who was pre-symptomatic but already contagious was sitting in the middle of the plane, and there were 13 people infected on the plane, 12 of whom were unvaccinated, and one who was sitting in the back of the plane, like all the way in the back of the plane, in something like row 60. And I may be misquoting, but it is a very infectious thing that can hover in the air, hover on surfaces, and really get past our typical mechanisms of hand washing and care that we can normally employ. I was also fascinated as an upper aerodigestive nerd to learn that measles has a hook protein that really targets immune cells. And so histiocytes, Langerhans cells that are out doing the surveillance work are the measles target. And so it can drag measles all over the immune system, all over the body, which is one of the reasons you get such more systemic side effects than with the typical upper aerodigestive viruses that are targeting the mucosa of the respiratory tract. It's also why measles virus and measles disease can cause a transient disruption of your immune function for other infectious diseases and can make you more prone to other illnesses, other types of pneumonia, other types of aerodigestive disease, because it can actually lyse your memory T cells that are there to fight those diseases. So measles is not only affecting you now, but it can cause a temporary shift in your memory immunity.
And we also know that there's as if the measles outbreaks continue, if we start seeing a resurgence in the seasonal patterns of measles, otolaryngologists will start to see those patients because, otitis media is one of the more common secondary effects and sensorineural hearing loss. So, so putting in tubes as well as seeing kids who now have nerve deafness. And then, it can also affect the labyrinthine system. So balance disorders and, sinusitis and pneumonias and tracheitis and those kinds of things. Those things are a little bit rare in terms of like the severe respiratory sort of upper respiratory trachea type problems, but they're not unheard of. And of course, we know the mortality rate being about 1 in 1,000, 1 per 1,000, 1 to 2. So ENT doctors will see it. And of course, I was thinking, we as we go through thinking about the symptoms, how many kids do you see, snotty-nosed kids do you see come to the clinic and they have mucosal lesions? Like those are a dime a dozen. And so, and the complex spots aren't always there. They can be very subtle, especially when they first start. So I think even as otolaryngologists, if you're in areas where there is a lot of vaccine hesitancy and there's a measles outbreak, you may actually be on the front line of seeing those patients.
I was just going to say, for all of the discussion in the news media lately about measles, for all of the attention that we've given it, I am struck by how mild the initial presentation can be. When I look at photos of kids with measles, when I look at the actual photos of the rashes, in particular in people with darker pigmentation in their skin, I think really hard to pick up the measles rash sometimes and recognize that that's what this is. And so measles is being broadcast loud in our awareness right now and in the news, but it shows up very subtle sometimes clinically, which I say from my reading, not my experience, because there's not a lot of that.
Yeah, that's probably why it's also so contagious, right? Because it's it's like a common cold at first.
So can we go into the timeline of symptoms and progression, and then go into the difficulty of diagnosis? And do we find ourselves in a position where we may be the first people to have to be like, is this measles? Like put this on our differential. It's not even just, oh, is it flu? Is it a bacterial sinusitis? Or is this measles?
No, I was going to say you can maybe give more insight, but I think that's one of the challenges that we're going to face. We're just not used to seeing those patients. And so, yeah, the textbooks, and it says, oh, you start off with a cold, upper respiratory tract infection, runny nose, sniffling, cough, all the things that you would see in just plain old coronavirus or any rhinovirus. And then it's the Koplik spots that appear a few days before that measles rash. That's pathognomonic. But, at that point, like, you have the measles. And so then after that, I guess the recovery is about a week or so for a lot of folks. But obviously, some people develop the severe illness and wind up hospitalized. And unfortunately, some will have that systemic inflammatory response where they pass away. I don't know, were you going to add something different, Daniel?
No, that's about the same. I think that from exposure to symptoms, you're talking a week to 2 weeks, unfortunately, with some degree of contagiousness right at the beginning of symptoms. Before the rash is evident, before the Koplik spots are evident. Incredible rhinorrhea I've heard described by my colleagues and friends who've taken care of measles patients, but that's every cold. And I think it emphasizes why it's so important for us to know vaccine history on the patients and vaccine history in the areas that they're traveling to. I think in times when measles is blossoming in our communities, we're going to have to change our clinic flows to specifically ask those screening questions of any patient with anything that looks like a cold. And I think if the patient is vaccinated and they have not been to an area where measles outbreak is actively happening, we can feel pretty good about the fact that a cold is a cold is a cold. But if any of those screening questions light up, we're in trouble. And I wear a hat as an operations leader here at my hospital, and the operational implications of having a measles patient in your area is huge and leads you to have to take actions. So I think screening for vaccine questions and travel, just as we did for COVID, is going to be an important part of managing outbreaks of measles in the future.
I'm curious, can you follow up on the operations piece? If you find out someone has suspected of active TB and they show up in your clinic, most institutions have protocols like, okay, you have to pick up the phone and you have to call this particular person. What's happening at Texas Children's if there's concern that, someone like in the emergency room or who walks into the clinic and it's like, oh yeah, this kid's got measles?
So I will qualify this by saying the first thing I would do is call my infection control friends and my infectious diseases friends.
Reach out. Yeah, that's right.
I'm going to reach out and touch someone. I'm not going to reach out and breathe after someone, but I'm going to reach out and touch someone and get their input, because you have to use things like negative pressure rooms. If you've had a measles patient in an operating room, you have to use a negative pressure room, and you have to maintain negative pressure for quite a bit of time afterwards. There are standards within the infectious diseases literature for what your hospital needs to do. You have to, a lot of it is thinking about where are we going to do their x-rays? Where are we going to do their CAT scan, that they need? Because these kids are awfully sick. How do we get them through the hallways to the ICU? And so I think every hospital in an area that starts to have a breakout is going to dust off the books and protocols that are out there. Like, the infectious diseases community has these guidelines, and we just have to employ them and get used to them. Fortunately, we have not been in an outbreak area in Houston or Dallas, right? We may get a patient, but we are not in an outbreak area. Outbreak area defined as 3 cases in a single area of public health surveillance. And so we definitely had outbreak areas in Western Texas, Northwest Texas, over into New Mexico, but did not at any point reach outbreak level in Dallas, Houston, San Antonio, the major cities in Texas.
So when there was an outbreak, quote, in West Texas, you guys in Houston and in Dallas didn't have to change too much of your protocols, but it may be that where I think a lot of hospitals all over we had the patient in the ED that presented positive for measles, and, here's the responses. That's kind of what you're seeing.
Yeah.
And then, I know the Department of Public Health for the state, don't they get involved? Because I think it has to be reported.
It is. It's a mandatory reporting to the Department of Health. And I mean, this year, I think 36, if I remember right, 36 states, state departments of health had to report measles outbreaks this year. No, excuse me. I may be misquoting that number. I'll get the right number.
That seems high, but I mean, obviously it was a huge outbreak here in Texas. I mean, it was the epicenter of the most recent outbreak. And I forget what the modeling shows. In terms of confirmed cases, I believe we broke the record in terms of 2,000 that they had previously. And so that means there's probably, it's one of these things where it's really, when you look at the historical data, when there was no vaccination, you had about 10 cases, roughly, maybe upwards of 20 for every one documented case. But that was no vaccination. So now we do have, we're not at herd immunity levels, but we're still like in the high 80s, low 90s kind of thing. And it's the unvaccinated populations are somewhat isolated from everyone else. So I think that is also going to be one of the challenges going forward, is how do you model outbreaks when you do have people who are vaccinated, you have communities that tend to be more isolated. We also have, I think, more active misinformation and disinformation. So how's the virus going to spread is much more challenging. In terms of Dallas, we had alerts, we had email chains, we had signage over the hospital. And, of course, in the School of Public Health, they helped model the COVID outbreak. So they're experts in outbreak methodology. So it never got to that point where they had to unlock those tools. But everybody was well aware and everybody was kind of looking out for that first case. Unfortunately, as far as I know, there were no measles cases in Dallas, not even like one that I can think of. Now, again, they may have been some that were undocumented or unconfirmed, but certainly at the hospital, I don't think we had any cases.
Yeah, I'll tell you, in Atlanta and San Diego, there have been cases, whether it's through the ER usually, and then there's the email chain and what's happening and things like that. So I think it is something that whether there's the outbreak of the 3 in the area of the site of public health to this one that's in the ER, the impact in terms of operations and how your hospital might have to manage it and how it may affect, maybe you had a patient in the ER at the same time that needs something. And that actually happened to one of my kids in Atlanta. And, now we have to change care for something else that they actually need care for, because now they have to, hopefully the Department of Public Health got a hold of the family. There's IMIG involved because the baby was an infant, couldn't get immunized, all that. There's so much there then that there's like a chain of events. I guess we can talk about, I kind of wanted to wait on vaccine, the diverse patient populations, and some of the screening questions. But then I also still wanted to get more in depth into some of the, I don't know if secondary is the right word, but some of the ENT sequela, right? Is otitis media after measles that different? What are the numbers in terms of sensorineural hearing loss and encephalitis? And maybe that information, to have some of that concrete data is helpful when we are talking to families. So I kind of put all this out there because that's where I'm at. Because I don't know if you knew this. In Dallas, there was an outbreak in 1990 or 89. It was like in the White Journal. And there was about 100 out of the 1,000 cases of measles at that time who were admitted. And 34 out of that 100 had airway obstruction, including like tracheitis. And so these are big numbers. There was like a study out of the Saudi Journal of ENT of a cohort in children in Nigeria. And they had 112 kids with measles-induced hearing loss. 70% were sensorineural and profound. I mean, it's high impact. And so maybe we can get into some of that and then go into when it comes to how do we screen for patients. And then, if we're screening, we're going to have to talk about vaccine hesitancy. And then should it be part of our routine anyways?
Yeah, I think
those are yeah.
They're
those
heavy.
Are heavy questions, Gopi. Oh my goodness. Well, first let me just say we don't, and again, Dan may may have done his research like you have. You need to do your own research. A lot of the data. So the problem that we face is that the old data is old data. It's data from a time when people weren't vaccinated. And you also was from a time when you didn't have deliberate misinformation and different disinformation populations. So the way the virus is going to spread is going to be different in terms of our modeling and our understanding is going to be different. So I think the primary thing is, I think you have to have within your differential diagnosis for kids who present with severe upper respiratory infection, severe sort of the colds, you got to start thinking about other viruses. Okay, first question is, are your vaccinations up to date? And then if their vaccinations aren't up to date, then you have to say, okay, we need to start looking at childhood illnesses, vaccine-related illnesses, or unvaccinated-related illnesses as well. In terms of sensorineural hearing loss and things like that, I don't want to misquote any of the numbers, but I know like the encephalitis, which is one of the most severe complications, about 1 in 1,000. But again, we didn't see that with this outbreak. And we didn't see any kids with encephalitis. The kids who did pass away, from my understanding, had pneumonia, which is about 1 out of 4 cases. But I don't know. And they say hospitalization is about 1/3 of the cases. And so I think, unfortunately, we may have to see more outbreaks to really start to model and figure out like, okay, how many kids are actually going to get sensorineural hearing loss? Is it going to be the typical, what you've seen in the 50s before vaccines, or is it new now because the spread of the virus is much different?
I mean, I always remember hearing, and I've seen in various places, that about 10% of the international cases of sensorineural hearing loss pre-vaccine were due to measles. And so I don't think we necessarily knew as well what the patient-specific risk was, but that up to 10% of attributable cases of sensorineural hearing loss in the world were due to measles exposure pre-vaccine era. And I think I agree with what you're saying completely, Romaine, that we're in a new era now. But I have to say, I feel a little bit, when I look at the long-term sequelae, sensorineural hearing loss, encephalitis, goodness help us, sclerosing panencephalitis, there's nothing we can do about it once the measles has happened. We don't have treatments that make that less of a thing. We don't know why some kids get panencephalitis and wind up dying, like absolutely dying, a 0% survival rate. Although I saw one paper that said 5% recovery rate with panencephalitis, but we don't know why. We can't stop it. We can't stop the sensorineural hearing loss. We can't stop the encephalitis. It's why we have to vaccinate. Like, vaccination is the only way we have to treat or prevent those things, is not to get measles in the first place. Once you've got the measles, that train has left the station and these things can happen. And I hate to be cynical, but it's the truth for now.
Let's address the elephant in the room. We have to come to it at some point. There's some people who say healthy kids don't get sick with measles.
Yeah, 30%. 30% of kids who get measles are going to have a complication of some sort. It might not be the encephalitis, it might not be sensorineural hearing loss, but they're going to get some sort of complication, and the quoted numbers up to 1/3 will wind up needing hospital admission. Now, maybe if we think back to the days of yore in the 1950s, pre-vaccine, with some romantic view of it, kids having measles out in the community and not going to the hospital. Well, we understand now that kids probably need to get to the hospital a little sooner than they did in the 1950s, right? Like we have a better way to assess their respiratory status. We're a little less tolerant of some of the bad complications. And so I think we have to be real about what Romaine is referencing, is that it's not just a cold. Can kill kids. We saw 3 deaths this year out of about, I think the latest WHO number said that we were up to about 1,375 cases in 2025 this year, with 3 deaths. We've always cited 3 to 4% death rate, but if we keep these numbers going, if we keep the case numbers growing, we're going to see the sensorineural hearing loss. We're going to see the encephalitis. We're going to see the sclerosing panencephalitis. It's going to happen.
3-4% is high. I mean, and that, when you think about it, that's not a low death rate for something that's preventable.
Forgive me, I misspoke. I want to correct. I want to have true data out there. It's not 3%. It's 0.03%. It's 1 in 1,000. It's 1 in 1,000 death rate. Excuse me. 1 to 3 in 1,000 death rate, not 3%. It's 0.3%. Sorry.
That's still a possibility. So in terms of addressing common myths, one of the common myths is, well, healthy kids may not get sick. What else have you, whether it's with the MMR vaccine or other vaccines, where's the hesitation coming from? What are the common concerns that parents have, and how are you addressing them?
I think, overall, we know that it's a spectrum, that it's not binary, right? There are people who just, they don't get vaccinated. They don't do it because they just don't have the time. They don't have the access. They don't have the health insurance. They can't take time off from work. And then there are those who are just, cautious. They're hearing things. I heard that, vaccines can cause harm or can cause these other types of things. And then there are those who are very accepting, like, oh, I'll definitely get my kids vaccinated. I'm going to do it when I go for my yearly visit. Maybe you missed the yearly visit. And that's the only reason why you didn't get your vaccines up to date, but you're willing to do it. And then of course there are those who's like, oh no, this is our 12-month visit. We got to go get our kid vaccinated. And then you also have the opposite, the complete rejection, where just strong anti-vax ideology and beliefs. And so I think about it in terms of in some ways it's like cultural hegemony, where, hesitancy is not just an individual, it's become a kind of an ambiance. It's the water that we swim in, and it's the water that they swim in. And so can I move the conversation in a direction from, strong hesitancy or caution to more, to accepting and people who are completely rejecting, that's a much more difficult conversation. But can I help those? And this is true for we deal with, Daniel, you deal with head and neck cancer. I put tracheostomy in kids who have serious illnesses. It's the same idea, the same principles, that sometimes you have to have these difficult conversations with families, and it's not about a fact. It's not about evidence. It's about belonging and ideology, and what does the waters you swim in, the people you're with say is important and not as important. And if you try to go against that group, the conversation shuts down. And so it's just trying to walk that fine line.
It's funny you mentioned that aspect of it, because I have taken care of lots of families over the years who have, for one reason or another, chosen not to vaccinate. And one of the only sure success stories I can share from a family changing their mind came from a family when I diagnosed their child with pertussis, with whooping cough. And they had been bouncing around the medical system, couldn't get an answer for why this kid had a chronic cough. And I managed to diagnose the whooping cough. And what changed their mind was not any of my conversation about whooping cough. It was when they asked me, because I shared with them that my wife was pregnant at the time. They asked me how my wife was doing. I said, well, she's kind of annoyed with me right now because we got to take antibiotics. And we got to take antibiotics because of your whooping cough. And my kids, I got 3 little kids, and one of them, two and a half, 2 and 1 cooking. And my kids, we got to take some prophylaxis right now because of the pertussis exposure that I got here in the office. And, and I'm a dad, and I understand all the anxiety. I have anxiety when I give my kids any medical treatment, and I know the treatments, but I have some anxiety. I mean, I watch my kid walk away to the operating room with my own partner for an ENT surgery, and I still have anxiety. I'm a dad. Like, that's real. That's normal. But, unfortunately, your choice on vaccination actually impacted my family. And, I've been taking care of this family for years and years and years now. They vaccinated their kids there. But we still deal with anxiety together about other issues in our care together. And so no amount of me lecturing them about the risks of pertussis and measles was going to be as effective as them seeing me as a member of their community, a fellow parent who had to deal with the results of their choice in my own family. And it came out of a really lovely, respectful relationship. Obviously, that's not the answer for all families who are choosing not to vaccinate, but it's the one ray of light in my history that I look to say, you know what, we need to keep fighting this fight. And protecting kids and protecting parents. No parent wants to bury their kid from a vaccine preventable disease. Whether they want to vaccinate or not, they don't want to bury their kid. Like people are, I just have to believe that we have to understand that they are not saying, I would choose for my child to die from a disease. And I think sometimes that can be the way it feels in the medical community. It's like, don't you understand that if you don't do this, your kid could go deaf and get encephalitis and die? And why are you choosing death? Why would you choose death? And it is not the way to start the conversation. That is not, no parent chooses that, right?
Prior to that visit with this family, with this patient, Danny, did the conversation of immunization or vaccine hesitancy come up before? Because I wonder if you repeated, you met a child, they're not vaccinated, or, that's part of the prior history. They're here for follow-up. And let's say it's for ear tubes, for recurrent ear infections. What are your thoughts for both of you in terms of, do you bring that back up? How do you, because you have to keep, right? What I'm understanding is there's a rapport to build. There is definitely that ENT physician relationship, but there's also nuances because there's community. Like, I get what you're going through because we have all these other human roles that we all play, whether it's parents, et cetera.
So this is tough because I'd like us to think that we all have the responsibility as doctors to take care of our patients globally. And I have to say that certainly being vaccinated against vaccine preventable diseases is as, if not more important than me improving your quality of life by treating recurrent tonsillitis, right? Like it is very, very important. But I also listen, I am grateful to have the perspective of my wife, their pediatrician, who is the frontline care provider whose true duty and responsibility it is to have these discussions at every visit with the families. And I don't think that we have the time to become that person for every patient. I think when we're aware of it, we can try to gently include education, gently include knowledge and risk. I see them a lot with sinusitis with my non-vaccinating family. So they're coming to see me for chronic sinusitis. And we have a frank conversation about Haemophilus and pneumococcus and the things that their child is experiencing and how many of that could be corrected by vaccination. And I have to say, I'm caught many a time saying, we should check their vaccine titer levels. And if they're not up to levels, then we'll revaccinate. When the family then says, point of order, they're not vaccinated. We didn't vaccinate them. And so I'm not going to claim any wonderful doctorally expertise about noticing the non-vaccination a priori. It usually comes up in the course of taking care of chronic disease.
Yeah, I agree with that. It's primarily going to come up as you take care of the patient and including that in your differential. I think that's where for otolaryngologists who are specialists, and I think we also need to think about, like, we're talking about measles, but we need to talk, it's not just measles, right? Dan talked about it was whooping cough. It wasn't the measles. That's where his exposure, but there's a whole host of childhood vaccinations. But guess what? There's more than just that. There's also influenza, and there's COVID, and there's pneumococcal. So how do you address a family who has a deaf child who doesn't want to get their child vaccinated? And you're thinking about doing a cochlear implantation. How do you approach that conversation? What if it's an adult? I mean, we're talking about kids, but it could also be an adult patient who doesn't want to get vaccinated. And so, the key always is first, if you find yourself in those conversations, to validate their concerns. It's tough, I know, because sometimes you hear stuff and you're like, whew, okay, where did that come from? But you try, I hear you're worried about someone. So we had an interesting conversation about kids who don't want to wear their hearing aids. And, the question was posed to the residents, what would you say to this teenager who doesn't want to wear their hearing aids? And I chimed in, I said, well, first and foremost, I would validate the patient's concerns and then understand where they're coming from, but then be understood and let them know that, okay, these are the consequences of your choices. And you do that in a way to let them know. The same way we talk about families, adolescents who have severe sleep apnea who are clearly overweight. Like I just have that conversation now. I'll say, hey, you have big tonsils, that's contributing to your obstructive sleep apnea, and you're also overweight. And I'll show them the weight graph. And I said, you should be down here, but you're up here. That's also contributing to your severe sleep symptoms. And so one of the things I'm going to do is I'm going to refer you to the nutritionist, because I think if we can get your weight under control, or under control, but if we can get your weight better, that's also. And I'm all surprised nobody gets offended. They're appreciative because you're approaching it from you're addressing their concerns, but you're presenting the evidence. And the one of the things I talked about in January, or was it May, at the meeting, was trying to make conversations like door handles. A door handle is, you see it, you just intuitively know, like, oh, let me turn and this opens up the door. You want conversations to just lead the patient to doing the right thing on their own accord, where it's visible to them, where you're not like showing it in their face. This is what happens when, this is your brain on drugs, the kind of thing, as opposed to having the conversation, even if it's just in a few minutes. Think about what Dan said at the beginning of the podcast. I don't know if he said that I took him out to lunch, and that was probably 30 minutes. And he said it had such an impact on his decision to pursue otolaryngology. So you never know the impact you're going to have on someone, even if it's just a brief 5-minute conversation.
So that leads me to time, because I think one of the audience members at the panel was, how do we have time? We have 15-minute visits. How does this fit in? And so then it makes me think, like, do I need to have a spiel? Like, what's my measles spiel? What's that? I got a tube spiel, I got a OSA, tonsil spiel. Or is that not the right way to think about it? Is it just take a moment to hear what they're saying, and maybe at the next visit, put them a note? How do you dance with that? Because there is a constriction of time, and no, we're not frontline, but everything we do, not everything, but a lot of what we do in pediatric ENT, tubes and tonsils, plays a role in infectious communicable diseases that have vaccines that can help. So in clinic, are there things that you guys recommend that other ENTs or APPs, providers can do in their clinic when this comes up?
I think one thing is to incorporate that discussion into the conversation when it is quickly and immediately relevant. For example, if I have a family who doesn't want to vaccinate their kids, then when I'm talking about the risks of needing a second set of tubes, when I'm counseling them about the ear tubes for the first kid, I will specifically call out the fact that, if we don't do some vaccinating between now and when these tubes come out, frankly, the chance that we're going to have ongoing recurrent acute otitis media is higher, and there's a higher chance of needing a second set of tubes. I'm trying to plant that seed for them to think about it. For my kids with recurrent tonsillitis, we talk about the fact that some of these are not going to be group A strep tonsillitis and could be other infectious diseases. And, if you're not vaccinating, they're still going to get sick. Like, I can make it, you maybe feel better, but you're still going to get sick. Sinusitis, especially, we talk about this in terms of the fact that it is probably not an anatomy problem. It is probably an infectious problem related to exposures to common childhood illnesses, compounded by allergies, sometimes anatomy, but boy, we may be able to really curtail this with vaccination. So I think I put it into the treatment conversation. I don't pull it out as a separate standalone conversation unless it is something really far out of my norm, like pertussis.
Yeah, I think adding it to the conversation for the particularly focused patient, like the otitis-prone child, the child who is having, it seems like much more often in severe cases of acute sinusitis and things like that. That's when you start, hey, are your vaccinations up to date? And just that simple question, that'll open up the door to more conversation. Well, we don't, I guess they could always tell you they are and not mention it, but they'll generally tell you like, oh, no, we're not getting vaccinated. And then that's when you can say, not that the CDC recommends you get these many vaccinations, but hey, as my experience as a pediatric otolaryngologist, I can tell you that children who are vaccinated, they have fewer episodes of acute sinusitis. They're less likely to develop chronic sinusitis. They're less likely to need surgery. And right now, I'm concerned that your child's going to need an operation, and they're a little bit young, and that surgery has some risk. I feel comfortable doing it. I feel I can do it in a safe way, but I can't eliminate the risk. And I know that kids who are fully vaccinated, the risk of them needing surgery is much less. So, again, then you et cetera, et cetera.
As you say that, Romaine, it strikes me that the way I talk about this is basically the same tenor to the conversation I have with smoking parents when I'm putting in ear tubes in their kids. It's not judgmental. This is going to increase the chance that we're coming back here. This is going to increase the chance that we're dealing with allergies and asthma and other things. I'm not judging you. This is what it is.
Same thing with obesity in terms of I've really had to talk to the residents about that. They would say, well, how do you talk about it? And I said, well, you talk about smoking cessation. You talk about you have to feel comfortable, and then it can't be done in a judgmental way. You can't, you know what I mean? If you do it in that way, they're going to shut down the conversation. But if you do it in a way that's hey, I know that kids who lose weight are less likely to have severe sleep apnea, that's different. And you've done your job.
No parent is sitting there going, man, I hope my kid gets asthma. That's not the deal, right? They want the best for their kids. And so, I try to respect them as people who love their kids first, and then conversation comes from them. I also think, though, that we have to be, if we are going down this path, we have to be very careful to be genuine. So, if I have a family who's not vaccinating and I want to talk to them about it, telling them that there is a 0.3% chance of dying from measles if your child gets measles, and a 1 in 100,000 chance of sclerosing panencephalitis, and a rare chance of sensorineural hearing is not, those numbers don't hit home. You're scaring them about a risk that is out there that's not really real. And I don't think that moves the needle for most people. I have a dear friend who shared with me recently that he and his spouse have never flown on a plane together internationally because they don't want to die together and leave their kids behind. And I'm like, come on, what are the numbers? Look at the numbers, right? The numbers of plane crashes and what are the, right? And that is a fixed belief that's not going to change by talking about very, very rare events. And I think in the same way with vaccines, talking about very, 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 very rare events may move some people, but I think talking about their real life, what they're really there to see you for, where it is actually applicable in that moment is more relevant. While we as a community of care providers start preparing for sensorineural hearing loss, the resurgence of airway disease from measles, we prepare for that. We maybe need to start doing the research for that, but that's not to move our patients.
I think there is something we can do collectively, though, and that is we have to be part of the process that changes the waters that we all swim in making getting vaccinated something that people who care about their children do, that people who want healthy children vaccinate their children, and making that part of the sort of
zeitgeist of the environments that we live in. So maybe our organizations, instead of, Medicare's about to cut our RVU rate by 5%, which is important, but maybe we should also spend time talking about the importance of getting vaccinated and providing the evidence that also that the members of those organizations can use when they have those conversations. Obviously, this conversation here is a part of that, to try to change the waters that we swim in, because it really is. It's at least the worst parts of vaccine hesitancy. The communities that are really like, oh, vaccines are dangerous, and it changes your DNA and it causes autism and those things. It really is about belonging. It's about belonging to a group, and that group is saying you have to have these beliefs in order to be a part of this group. And so can we expand the sense of belonging, where it's like, no, we also care about our children. We also want healthy children. We know information helps us make better decisions. We're also thoughtful parents, and we want you to be a part of our group.
Yeah, no, that's super interesting. As we start to round it out and kind of going off of what you just said, Romaine, about being part of that process of changing sort of the water, changing the juice that we drink, right? Getting people kind of on the same page. From your public health hat in the medical school or research, and you, Danny, as you become the president-elect and have like this leadership role in our national society, what are ways that we can do that collectively? We talk about we talked about one-on-one patient care, making it relevant. We've talked about, hey, there may be some research that we're going to have to start including and looking at this patient population and what the impact is. What are we seeing? We talked a little bit maybe about advocacy as well, but what are some other, maybe as we start to round up final pearls, or where you might see the gap or future? And it may be from an operations level. You mentioned vaccine questionnaire screening that might have to come up when there is an outbreak or when there is an exposure. Who's going to be responsible to mandate that or put that? Is it going to be a hospital system thing? Is it something that should be coming from our organization? I mean, we kind of had a little bit of that with COVID, right? PPE and sort of getting that in place for us as otolaryngologists really came from our national societies and our societies that kind of backed us up. I thought was very helpful in pushing for some of that. So, any, I guess, final big thoughts.
I think the first thing we can do is what you've done by giving us a chance to share this conversation. Dr. Johnson and I think I can speak for you too, Romaine. We're not measles experts, but this conversation needs to be amplified, as with all emerging dangers in our community. I was lucky to travel with my family a good bit this summer, and I made it a habit to look up who the local ENTs were in these small, out-of-the-way places we were traveling to in beautiful parts of the world, just so I could call them and ask for locums jobs. No, just so I could find out who's where, who are the ENTs in Sitka, Alaska, for example, because we have to make it easy for our colleagues who are on the front lines of healthcare to have reliable information at their fingertips. We have a job as organized medicine to collate the messaging in ways that get beyond the fear and beyond the hype of the general media to educate our community about what to be alert for and how to pay attention. So I was really grateful that Anna Mesner and the Triologic Society put together that panel at COSM. I'm really grateful that you put this together today. I think there's an ongoing role for education through our academies to make it easy for our members, for our fellow otolaryngologists to have easy access to best information so that they can take care of their patients. So that's my first thought.
So I think one of the things we have to remember is, hesitancy isn't just a knowledge gap. It's also a trust manipulation problem now. And, we're not just, unfortunately, the people who've attacked COVID treatments and vaccines, they're now attacking vaccinations in general. And we are seeing a little bit of a cultural hegemony, in the society where anti-vaccination sentiment is taking hold. And so we have to start thinking about being more engaged, at least collectively. Individually, I think all the things that we shared. It's when you're in a clinic with the patient, you address the patient in front of you. But I do think in terms of a reality check, we have to start thinking about motivational interviewing techniques. We have to learn how to practice evidence-based medicine in environments that sometimes may be hostile. And we have to work on building networks and advocacy across organizations in order to provide some protection, and protection may be too strong a word, but just ways for people who are actually interested in keeping everyone safe from highly preventable illnesses have the tools they need to do it.
I think we can also frame shift a little bit as well with our resources to the international and global community. There is going to be a portion of our community that is not going to vaccinate, and we should not give up the fight, but they're not going to. There are going to still be 100,000 cases of measles globally this year, and there are going to be 3,000 pediatric deaths from measles in the world. There are going to be thousands of children with sensorineural hearing loss globally, and we've got great organizations out there working on vaccination around the world, and we need to support them as well. I would hope that we could be a leader in vaccination, as we always have been, and maintain that role. But we also need to support our international colleagues who are making a difference for an even more at-risk population.
This is great. Well, thank you guys so much. I learned a ton. And, if there's other ways that we can keep the conversation going, I would love to be able to do that. I think there's always a learning opportunity and just great to share ideas. So if you guys want to come back on, or if any suggestions, and of course, for any of our listeners, please reach out. Romaine, Danny, if anybody has questions or want to reach out to you, are you guys on any social media? Or if not, they can email us at BackTable and we can connect you guys or try to convey any messages.
I'm on all the social media. I'm on all of it. But for my mental health, I don't look at it all the time. Reach out on LinkedIn, reach out on Facebook. I'd love to talk.
Yeah, same. I mean, yeah. I think I'm on most things, but I don't post that much. I try to post a little bit on LinkedIn and things like that, but probably to catch me at a meeting but sure, you welcome to reach out. Looking forward to the conversation.
Great.
I will say, I think I gave up my MySpace account in 1997.
But never had a MySpace account.
It was very, there were lights. It was a whole thing. It was great.
Yeah.
Awesome. I think it's a wrap. Thank you.
Thanks so much, Gopi. Thank you.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Legrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.